Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'll be your host tonight for our program on orthopedic problems and joint replacement. We'll be taking your questions about sprains, strains, broken bones, joint replacement, and any other orthopedic problems you might be wondering about. Remember, the success of this program depends on your questions. Please call the numbers at the bottom of your screen and we'll do our best to get your questions answered. I'm pleased to welcome our panelists this evening. Dr. Dave Hutchinson, a family medicine physician with St. Luke's Lester River Medical Clinic in Duluth. Dr. Dave Rust, an orthopedic surgeon with St. Luke's Orthopedic and Sports Medicine in Duluth. And Dr. Joseph Signorelli, an orthopedic surgeon with Essentia Health Duluth Clinic. Our medical students answering phones tonight are Lee Kay of Dassel, Minnesota, Abby Sauer from Forest Lake, Minnesota, and Casey Thiessen from Wadena, Minnesota. And now on to tonight's program on orthopedic problems and joint replacements. Well, Dr. Hutchinson, let's start out with a question here. You're a family physician, so certainly patients come to you with orthopedic problems also that say don't require surgery. Is that right?
Oh, for sure, yeah. We love to see orthopedic problems in our office. And we like to do an initial assessment, and we have x-ray available in the office usually in most of our clinics. We sure appreciate having our orthopedic colleagues for a consultation by phone or in person when we need additional help, but you bet we take an initial stab at most simple orthopedic problems.
Okay, well, thank you. Dr. Rust, there's a question here. An MRI report said that there's a tear, so this patient wanted to know why didn't he have surgery performed? When you have a tear, say in your shoulder or your knee, is surgery always needed?
Well, I think it's a great question, but really I think that's why you're going to see the surgeon, so that they can take that information, combine it with the history that the patient gives you, as well as the exam that they perform, and decide whether or not that tear, not only is it related to the type of symptoms and pain that you're having, and is it the type of tear that would be best treated with surgery or perhaps with an injection or therapy. But we do spend a lot of time educating and counseling and trying to make that decision together as to whether or not that tear does need surgery.
Okay. Dr. Signorelli, are there new types of joint replacements now, or have things changed a lot in the last few years?
Well, I think things have changed quite a bit in the last couple of years, and in a way we've gone back to some of the things that were used, say, a decade ago or so. We've tried new things in the lab, and some things work out very well in the lab, and once you get it in the human body, it doesn't perform the same way. So I think there's more of an emphasis now on doing a joint replacement that has a track record that shows that it will have tried and true results.
Great. Well, thank you. Dr. Hutchinson, typically, and I get involved with this too a lot, we do preoperative exams on patients. Why do we do preoperative exams on everyone?
So I appreciate the question. Well, first of all, the primary care docs tend to know patients best and most thoroughly, and our surgical colleagues and anesthesiologists sure appreciate when we can have a full complement of information about each individual patient, all well recorded and available for their information and reference so that they can take proper care of the patient in the surgical setting. There are dozens and dozens of reasons why we would want to do preoperative exams, especially if anyone has any other, how we say, comorbid medical conditions. Mm-hmm. We want to these are elective procedures by and large when we talk about joint replacement. It would be terrible to have something devastating medically go wrong during surgery, so we want to do everything we can to minimize that risk. Sure. We want to make sure cardiac or heart status is as well tuned as we can help it be, and that pulmonary or lung status is as well tuned as we can help it be. We want to review all patients' medications to make sure those don't need to get adjusted around the time of surgery. We want to make sure that they come off aspirin at an appropriate time, that they come off other medications that can be risky around the time of surgery. For example, medications that can that can increase the risk of infection. We want to make sure people physiologically can withstand the stress of surgery. And some joint replacement surgeries, there's a fair bit of blood loss, and there are a lot of, intravascular fluid shifts. And we want to make sure people's hearts can withstand getting a lot of fluid, and that their kidneys can help process that fluid. We want to make sure people can tolerate blood loss from a physiological standpoint. There are lots of things to go over and catalog and have in order before people undergo surgery, especially elective surgery.
Well, thank you. Dr. Russ, we have a question regarding a shoulder replacement process. What are the difficulties with the surgery and recovery? Shoulder replacements, that's a pretty big deal, isn't it?
Yeah, shoulder replacements are generally performed when patients have advanced arthritis, and we've tried non-surgical treatments like injections, therapy, even some arthroscopic procedures. But once the shoulder has gotten to a point where it's worn out, I think the first question is what type of shoulder replacement. There's a new technology called a reverse shoulder replacement. So some patients come in and say, well, isn't this better than a standard total replacement? And really there's those two types of shoulder replacements are based on the function of the patient's rotator cuff. So we know rotator cuff problems are frequent, and in patients who have rotator cuff problems that are not fixable with surgery, they can go on to then wear out their shoulder. And those candidates, those patients are best treated with what's called a reverse shoulder replacement. If you don't have, if you do have a functional rotator cuff, then a standard total shoulder replacement is really the best treatment. And the recovery for that is about 1 to 2 days in the hospital, and then about 6 weeks of healing time in a sling to allow the actual surgery to heal. When we do the surgery, we have to open the shoulder, and we actually have to release one of the rotator cuff tendons. At the end of the surgery, once the parts have been replaced, we actually have to repair that tendon. And so there's a 6-week healing time after a shoulder replacement where we really have to allow that rotator cuff to heal together. And that probably determines more about the recovery than anything else. Sure. After that 6-week period, you then have to go through physical therapy and regain your motion. That's kind of the general recovery process.
Well, thank you. Dr. Signorelli, a caller here from Hayward, would like to know, can they do joint replacements in your hands too if you have bad finger joints?
Certainly. That is an area that is prone to arthritis just like all other joints within the body. And so certain joints within the hand, if it gets to a point where the cartilage is completely worn out and all other non-operative measures have been tried and are not successful in terms of treating the symptoms, then there are joints that can be replaced in the hand.
Sure. Dr. Hutchinson, here's a caller from Duluth, wants to know about calcium supplements. Do they help heal fractures or prevent fractures?
So that's an interesting question. Adequate calcium is important for adequate bone healing, absolutely. People who are calcium deficient, we would be worried about healing along an appropriate timeline. As it turns out, we're discovering that dietary calcium is healthier for some reasons than calcium supplements are. We've spent a lot of years prescribing calcium supplements to help make sure people's bone mineral density stays well enough or healthy enough to minimize the risk of fracture as they get older, as our bones naturally get thinner. It turns out that increases the risk of some other health conditions a little bit. We think it increases the risk now of heart attacks a little bit. We think it increases the risk of kidney stones a little bit. Sure. There is some conflicting evidence about those things, but it turns out dietary calcium lowers the risk of both of those conditions. And so now we're working hard to try to make sure people get adequate calcium in their diet rather than simply prescribing supplements. But yes, adequate calcium intake is important for bone healing.
Thank you. Dr. Russ, caller from Superior would like to know, she's allergic to metals such as nickel, cadmium, and chromium. How does that affect a knee replacement?
I think it
Metal
greatly, a metal allergy is a very important piece of history to tell your doctor, especially your surgeon, and I'm sure Dr. Signorelli agrees with this. It can affect and change the type of implant that we select. And so there
are options.
There are options for people who have metal allergies. The most important history, I think, what I've always heard is if you have reactions to pieces of jewelry on your skin. So if you've ever had types of jewelry that you can't wear, let your doctor know that, because there are some implant choices that we can make, even some allergy testing that can be done preoperatively to determine your risk, and potentially that could save you from having a potentially bad reaction if that history wasn't known.
Interesting. Thank you. Dr. Signorelli, we have a couple of callers wanting to know about how long do knee replacements last, total knee replacements?
It's a little bit of a tricky question to answer. It's a great question. A lot of what we base our answer to that is how long knee replacements have lasted in the past. And I think we think and we're hopeful that the technology now will lead to longer lifespan for these replacement parts. So most of the studies suggest that they last quite a long time. They tend to fail at about 0.5% per year for the first couple of decades. So 20 years out from surgery, most studies suggest that about 90% of patients still have a well-functioning total knee. Mm-hmm. A lot of how long they last is a little bit like treads on a tire for a vehicle. So it depends on how you use it, what type of activities you're doing, and some of that is dependent on how young or how old the patient is when they have their joint replaced, and other factors such as that.
How active they are? Does that
Absolutely.
make a difference? Sure.
In general, it's good to stay active after a joint replacement. It's good for overall health, helps keep body weight at a healthy weight, which is important for longevity of joint replacements. There are certain activities, though, that we'd want a patient to stay away from, such as repetitive high-impact activities.
No skydiving?
No skydiving.
Oh, okay. Dr. Hutchinson, we have a couple of callers here wondering about diet. What do you have to say about diet and supplements for cartilage? Are there things that will help cartilage remain healthy?
I think the best answer to that question is that a healthy diet, which means adequate lean protein, lots and lots of fresh fruits and vegetables, not very much fat, limited or measured amounts of carbohydrates, and plenty of active exercise is without repetitive heavy weight bearing is what helps keep cartilage healthy. There are some people do, the question may stem from a question about cartilage supplements like glucosamine and things like that.
Right.
And some people do have joint pain relief when they take glucosamine supplements. Not everybody, but some people do. Some people are responders. You have to take it for a while to know if it's going to help, but it can help. There are lots and lots of products on the market that advertise themselves as being for joint health and cartilage health. Most of them have some form of glucosamine in them, and that's probably where most of the benefit comes from.
Well, thank you.
Yeah.
I just should also remind everyone that we do have the calling numbers here. Locally, it's 728-2844, and we have a toll-free number, which is 1-877-307-8762. Dr. Russ, a caller from Clover Valley would like to know, what are the symptoms of avascular necrosis of the hip joint?
Pain. The primary symptom would be pain, and there are some historical things that can put you at risk. So a history of steroid exposure from medications, treatment of rheumatoid arthritis, history of heavy alcohol use can actually cause avascular necrosis. But primarily it's pain, and it's usually in a relatively young patient, so a patient perhaps in their 30s, 40s, and 50s. There are other times when avascular necrosis can result as the from an injury, a trauma, or a fracture. And typically, if that original injury occurs, your doctor should let you know that we need to monitor this and watch for signs of worsening pain.
And where is the pain? Where is it located?
Pain,
Over on the side, or?
pain would typically be deep in the groin area.
Oh, okay.
So hip joint pain, ball and socket joint pain is typically distributed either into the deep front of the hip and the groin, radiating down the inner side of the leg. Occasionally people will say it's from the side or in the back, but it would be a deep pain.
Thank you. Dr. Signorelli, we have a caller from Duluth would like to know, he's has a very much of an intolerance to the opioids, causing a lot of nausea, vomiting, and that. Is there something else that can be used for pain after surgery?
Certainly, and I think there's more and more research going into this, and we're trying different modalities, and there's a lot of information now that suggests that it's a lot more effective to try to block the pain ahead of time and prevent pain rather than treat it afterwards. So we're trying to do things in terms of giving some medications prior to surgery. We're trying to do things in surgery to try to decrease pain afterwards. There's pretty strong evidence that different types of anesthesia can lead to less pain afterwards. There is some information that we can inject some medications during surgery to try to prevent pain afterwards.
Sure.
So, and then there are different things that we can do in surgery in terms of respecting the tissues and the other areas around the area that we're operating, so that, for instance, after hip replacement, in a lot of patients we try to use no narcotics at all afterwards.
Okay. And if I could pick up on your theme of pre-surgical treatment of pain, or prevention of pain, that's wonderful, and I think it's important to highlight too the potential for physical therapy pre-surgically to really accelerate the recovery process after surgery and to lessen postoperative pain for some body types.
Absolutely.
And some joints. That's great.
I agree with that 100%. I tell all patients that surgery itself is kind of like an injury. And so it's hard to pick up any new exercise after an injury. So if your body is used to that exercise prior to going into surgery, it's a lot easier to do the things you have to do afterwards to get you back to where you want to be.
Good, interesting. We have quite a few callers calling in about supplements and diet, which is a good thing. Another question to you, Dr. Hutchinson. What kind of foods should one eat for calcium? You mentioned that.
Oh, so that's a good follow-up, and I appreciate it. Well, you get your biggest bang for the buck with dairy products. We want the equivalent of about 3 dairy portions a day, calcium-wise, to get enough daily calcium in our diet. And a dairy portion is defined as 8 ounces of milk, or 4 ounces of yogurt or cottage cheese, or 2 ounces or 2 thick slices of cheese. There are other forms of dairy. There are other. You can also get calcium from soy milk and almond milk, though at a little bit lower concentration. There's good calcium in dark leafy green vegetables, but you have to eat a big plate of kale or collard greens, which actually has more calcium than spinach or kale, to get the calcium that's equivalent to 1 dairy portion. So for sure, some people watch fat intake and some people don't eat dairy or are lactose intolerant. It's possible to get calcium from other sources, like soy milk or almond milk, and with dark leafy greens, but dairy products are the easiest way to get dietary calcium.
Very good. Here's a question to Dr. Russ. How long do rooster comb injections last, and are they successful?
That is a great question.
I'd like to know that myself.
Yeah, I think, again, like Dr. Hutchinson mentioned, there are responders and there are non-responders, so they don't work for everyone. So giving a blanket answer saying you should expect this much relief is not really how the medicine works. So everybody responds differently.
Do some people really respond?
I think, yeah, definitely people are responders.
Okay.
But there is a lot of investigation going on right now as to whether or not we should be recommending it as much as we are for the treatment of early arthritis, and I think that's a bit controversial right now. We don't know what the future is going to hold. I think the more information we get, the more we see what the recommendations are from our national governing bodies or the academy, I think we'll see whether in the future we continue to utilize those rooster comb injections as much as we are now.
Thank you. Well, we've got a lot of questions here and not much time left. So here's a quick one. Does anyone in Duluth, Dr. Signorelli, does anyone in Duluth do elbow replacement surgeries?
Yes, there are a couple of members. I know certainly I can speak to our department, a couple of members that do elbow replacement. I was talking to one of the surgeons today about that. Elbow replacement is interesting in the fact that it used to be quite a bit more common than it is now. With the advent of some of the medications that are used by a lot of our medical colleagues to treat diseases like rheumatoid arthritis, they're kind of preventing the damage to the joint from rheumatoid arthritis prior to it occurring, so that the incidence or the need for elbow replacement is a fraction of what it used to be, say, a decade ago.
Thank you. Dr. Hutchinson, does constant impact from jumping out of planes, marching in the military, can that cause cartilage loss over time in joints?
I'd be interested in the surgeon's perspective on that because they actually get to look at it in surgery. Any repetitive motion can cause overuse type injury. Shoulders are famous for wearing out at older ages when they get used heavily. But I think the real answer depends on each individual's body mechanics. We're all put together a little bit differently with different angles and different physics. We also have different genetics. Some people are prone to cartilage loss and destruction later in life, and some people are a lot less prone. And so having the right parents is certainly as good as monitoring your activities.
Thank you. Dr. Russ, we're talking about replacing things. How about ankles? Is there ankle replacement?
Yes,
joint?
and ankle replacement is it's a fairly high specialized procedure. It's typically a surgery that is done by a foot and ankle orthopedic specialist or foot and ankle surgeon. And so that's an interesting point. Just because someone says that they're a joint replacement surgeon doesn't necessarily mean that they replace joints in hands, ankles, and so.
So the orthopedic surgeons, a lot of them tend to focus on certain areas.
In certain areas, exactly.
Subspecialty in certain areas.
Right.
I, for instance, just do hip and knee replacement. So orthopedics itself is really a very broad field.
Of course.
And there's some evidence that, like anything else in life, the more you do a one thing, the easier it is to be proficient at that.
Well, since you do knee replacements, here's a question for someone calling from Holyoke. If you have a knee replacement, can you still bend down to clean?
Yeah, you can still bend down to clean.
Can you kneel?
Yeah, it all depends on who you ask. There's no definitive study or no definitive answer on that topic. In general, I tell patients that after surgery, they should expect that they can kneel down. Since the incision for knee replacement usually goes towards the front part of the knee, it's somewhat uncomfortable to kneel on that incision. So I usually tell people to plan on using a knee pad if you're going to be in the garden or in the garage or something where you're going to be kneeling down, but we don't think it's actually going to hurt the replacement parts.
Thank you. Dr. Hutchinson, I'll ask you this question. Maybe you'll have to ask the orthopedist, but
Thank you.
after carpal tunnel, does it have to be done a second time? Can sometimes carpal tunnels come back and have to be redone?
It's unusual. It's possible. There are a number of conditions that can contribute to a scarring or thickening of the tissue that forms the roof of the carpal tunnel in the wrist. Usually not. It's probably the right answer. Carpal tunnel surgeries are quite simple, and they're highly effective when they need to be done.
Thank you very much. And Dr. Russ, if people have say a knee replacement and they're having troubles, are cortisone shots given in addition after a replacement or for a hip or something like that?
Typically not. I wouldn't say that it would never be done because I think that it's possible, but I would say you would certainly want to counsel your surgeon and potentially talk to them about whether or not the knee replacement is functioning properly or maybe there's some other thing that's causing the pain before having the injection.
Well, while we're out of time, I'd like to thank our panelists, Dr. Dave Hutchinson, Dr. Dave Rust, and Dr. Joseph Signorelli, and our medical students, Leah Kay, Abby Sauer, and Casey Thiessen. Next week, please join Dr. Ruth Westra for a program on eye problems, when her panelists will be Dr. Lisa Graham, Dr. Joseph Morehouse, and Dr. Timothy Quinn. Thank you for watching, and good night.